So we're going to demonstrate a few methods for working on the clavicle that Dr. Still talks about that are likely to work, where the other ones that he talks about maybe a little bit less likely. Also, with respect to the standing one, I don't know that many people are going to appreciate being pushed up against a door frame or door jamb. So the standing one can be done. It's the same concept and same movement, but the thing that we'll show is generally what he talks about with the SC joints, and then what he talks about with the AC joints. The SC joints, the point that he seems to be trying to make is you're going to try to get the acromial end behind the sternal end of the clavicle. So it's essentially shoulder retraction. Maybe that's not the best way to put it. It's not really shoulder extension, but it's trying to tip the clavicle. Now there's multiple ways to check the SC joint. Essentially, does the clavicle go up? Does it go down? Will it go backwards? Will it go forwards, right? So if you want to make the clavicle go forwards and see if the SC will go all the way, you literally just lift it, right? And then you'd have palpation here. With respect to the methods that Still talks about, the first one is simply springing it. So all he does is he goes to the ends of the shoulders and he pushes down to try to pop the sternal end of the clavicle up, and by pushing the AC down. So essentially it would just look like this, right? Now, this isn't going to be very specific because you can't tell what you're doing. He does talk about doing this on both sides. If you adjust it and you come to the sternal end of the clavicle that of the side that you're on, you can do this and you can palpate it. Now the problem is her whole torso is moving, so it's not really doing what I would want. But Still literally just talks about this. Now if you do want to do it on both ends and your thumbs are big enough to get from the end of their shoulder to around their SC, you can do this. The problem is I can move this one really well. I can't move the other one really well. It's just angle. I've got a bad angle, so it seems to work better when you're working on that side. The other thing that he talks about with the SC is that you bring the arm over here, then you do this. Now you can see, or you should be able to see, that her head's moving and her torso's rolling. So again, not as specific to the SC as maybe one would hope. With respect to the AC, there are methods he talks about where he doesn't specifically note stabilizing the clavicle at the acromial end. The way that you do it usually is you get behind it. So if the patient is in supine, you hook behind it. It can be quite tender there. And then the movement after that is fairly straightforward. So what you do here, hook behind. He does talk about kind of pulling it up, coming across, and then coming backwards like a semicircle. So you can just do that. What I tend to do to adjust it is I get really close, pull across, and then I pay attention in multiple ways to where I get tension on it, and I use my body more than my arms. And then often you will get a bit of a click. The other thing that he talks about, being behind that clavicle and driving the arm down. Straight arm doesn't work as well, but if you bend the arm and you use the elbow, you can just push straight back. Often really tender doesn't work as well. Making that larger movement works a little bit better. Also talks about being here and basically just pulling the arm back. He does talk about using his thigh in some ways and making fulcrum, but just pulling straight back. The challenge for that with the AC is that the clavicle is going to move a bunch. So really you want to be able to stabilize that AC and work on essentially using the arm to move the scapula in relation to a relatively still clavicle. So a few methods, trying to make some adjustments to them to make them work a little bit better. It's also really, really easy in lateral. Essentially, you get behind the clavicle for the AC and you can pull the arm back or wherever it needs to go. As with anything else, you have to pay attention to how the patient responds and to the minor movements that you have to input to that person to get the movement you want. So you can't just do that circle that Still talks about. Sometimes you have to do a lot of minor movements with that arm in order to get it to, or in order to get that still clavicle and moving scapula to get the movement into the AC the way you want.